Okay, thank you. It's really nice to be here, and I have a very big topic, and I've been allocated 25 minutes, so I will endeavour to complete the talk and maybe save questions towards the end. And I'm very happy for people to have copies of my presentation, so you don't need to write. So let's just begin. And I thought I would start with the words of Dr. Brian Matthews, an Oxford neurologist. And he wrote that the best test of a physician's suitability for the specialised practice of neurology is not his ability to memorise improbable syndromes, but whether he can continue to support a case of motor neurone disease. I think it's a very astute observation, and I think one that recognises the complexities of looking after people with MND, and that perhaps the care should be more practical and holistic in nature. And I think this too is also reflected in the work of Patrick Joyce, who's a Bristol-based artist. He too suffers from motor neurone disease. And what he wanted to do was he wanted to paint 100 portraits before he lost the ability to paint. And he decided that he wanted to paint the people who cared for him, who supported him. And so you've got his neurologist, Dr. Martin Turner, up at the right, but he included a whole host of people. Earl Venner, who provided equipment, and there's Julia Franklin, who was a fundraiser for raising funds for motor neurone disease, his wife, his carer, and Dr. Goodall, who was a research scientist. So it's just to point out that really care should be holistic and that multiple teams should be involved. And by multiple teams, we're not just talking about the doctors in each team, but a multidisciplinary approach. So physiotherapists, occupational therapists, chaplains, social workers, doctors and nurses. And where I fit in is at the bottom in palliative care, which has been defined as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. A palliative approach will ensure early discussion about future care management decisions and advanced care planning, and also will ensure optimal symptom and wellbeing needs for the person with MND and their carers. And we aim to assist people with MND to maintain their quality of life and to support their carers to maintain their own health. Now, in essence, I think everyone in this room does a little bit of palliative care. Motor neurone disease is an incurable disease. Average life expectancy, I think, is about 3 to 5 years. And I think it's fair to say that from the time of diagnosis with motor neurone disease, it is important to adopt a palliative approach to all aspects of the disease. So I'm going to start talking about some of the physical symptoms that we encounter in motor neurone disease, but I'm going to borrow some words because I don't think I can express it as well as some of the people who have suffered from motor neurone disease. And this is Maurice Schwartz, who I'm sure a lot of you will know from the book Tuesdays with Maury, which has been made into that successful movie with Jack Lemmon. He was a sociology professor, and this is how he described how he felt in some days. There are days when I am depressed. Let me not deceive you. I see certain things going and I feel a sense of dread. What am I going to do without my hands? What happens when I can't speak? Swallowing I don't care so much about, so they feed me through a tube, so what? But my voice and my hands, they're such an essential part of me. And once this thing hits my lungs, talking may become impossible and I'm just too fatigued. So there you have it, some of the symptoms of motor neurone disease. More commonly we see dysphagia, dyspnea, weight loss, speech problems and pain, and less commonly constipation, drooling and emotional lability. So let's start with one, dysphagia. This happens when you have weakened muscles in chewing, in moving the bolus of food and swallowing. Practically, what can we do? Careful feeding, positioning the patient upright, choosing the right consistency of food. Oh, I'm sorry, I thought you had a question. And giving small, frequent meals, taking time for eating, and enlisting the support of family members to help with feeding. And then the involvement of speech and language therapists and dietitians is appropriate. And PEG feeding, the indications of which include acceleration of weight loss with dysphagia, frequent choking, exhaustion with eating, and impaired quality of life. Now, Peg feeding, as you've heard, can be done a couple of ways, but usually does require an anaesthetic or some degree of sedation, so it is best done while the respiratory function allows for a safe anaesthetic. And once the peg has been inserted, you can use it whenever it's required. And if the person still derives pleasure from swallowing and can do so safely to some degree, you can combine oral and peg feeding. I won't go into the respiratory symptoms. We've just had this, the lecture preceding mine. I just wanted to say that when you do get worsening dyspnea, you may need to use small regular doses of morphine and lorazepam. And I just wanted to point out that if used appropriately, benzodiazepines and opioids will not hasten death. Just the average doses, the use of opioids in motor neurone disease. Looking at oral morphine, we find that the mean dose is 96 milligrams over 24 hours, and the median dose is 60 milligrams over 24 hours. The mean duration of use is 95 days, and these are relatively modest doses compared to the doses we use for other terminal illnesses. So we'll move on. We'll move on to communication, and this is David Niven, who, as most of you will know, is an actor and wrote a couple of biographies and a spinner of yarns. And his son, David Niven Jr., basically felt that his father suffered from the weakness and difficulty swallowing, but much worse was the way it affected his speech. Out of every 20 words he said, only one could be understood, which was very frustrating for him because his mind was unaffected and had been such a marvellous storyteller. And this cruel disease took away what was so very special about my father. Interestingly, that quote came from the Daily Mail, this British tabloid, and I think the article was the truth about Dad's deathbed confessions, and certainly had a lot of racy confessions for someone who could get one word out of 20, so I'm sure they used every communication aid in the book. So for impaired communication, we ask our speech therapists for support and communication aids. So I guess my patients, if they still have power in their hands, their fingers, they do use their iPads, iPhones, and the Canon communicators and those light writers. Sometimes they lose power in their fingers, but they can still hold a pointer, and then you can give them a board and they can just spell the letters out. They lose function of their hands. You have these boards, some of these transparent Etron boards, I think they're called, with the letters spelt out, and you can track eye movement on the other side and spell out what they're trying to say. And I think the most extreme case I had was a Cantonese, non-English speaking patient who could not use his limbs and could not verbalize at all. And so we communicated through a translator using yes-no questions, getting him to blink once for yes and twice for no. But I just want to point out that we were able to get some sort of dialogue and a conversation going, so there is always something that can be done. This is Tony Judd. He was he was a historian, and he was professor at New York University. He died from motor neurone disease. Very articulate man who wrote a series of reflections on what it was like to have motor neurone disease. And I thought that he was able to really capture what it was like to have pain in motor neurone disease. So he wrote, "Ask yourself how often you move in the night. I don't mean change location altogether, merely how often you shift a hand, a foot, how frequently you scratch assorted body parts before dropping off, how unself-consciously you position yourself very slightly to find the most comfortable one. And imagine for a moment that you had been obliged instead to lie absolutely motionless on your back for 7 unbroken hours and constrained to come up with ways to render this Calvary tolerable, not just for one night, but for the rest of your life." And I think he just nailed it with that statement. So people with MND suffer from musculoskeletal pain, joint pain and stiffness, muscle cramp, and skin pressure pain when the position is unchanged. Practically, we can use mattress support, positioning, range of movement exercises and physiotherapy, very important, non-steroidal anti-inflammatory drugs, and for skin pressure pain, low-dose opioids, what we start with. I have listed the drugs that can be used for cramping and spasticity. For spasticity, I tend to use baclofen, benzodiazepines, but I have listed all the drugs that are in the literature. So this is Lou Gehrig, famous American baseball player. And James Kahn, a sports journalist, wrote about him before his diagnosis of motor neurone disease. "I've watched him closely, and this is what I've seen. For some reason that I do not know, his old power isn't there. He is meeting the ball time after time, but it isn't getting anywhere. So limb weakness. Physiotherapy is crucial with regular exercise of muscle groups, orthotics, and aids for mobilisation. I mean, there's a whole range of them, from walking sticks to wheelchairs. I believe you're having a talk on that later today. A quick note on sexuality, that most people who suffer from ALS preserve sexual function. So at some point in the history, if they're wanting to talk about this or delve into this, it's very important to explore this. Not just really for the motor neuron disease patient, but for most of the other terminally ill patients as well. Constipation from immobility, from diet. So starting regular aperients, enemas, and adjusting diet appropriately. Secretions. So you can get reduced swallowing of normal saliva, and you get pooling of the saliva, and they can become tenacious and quite thick because of dehydration and mouth breathing. And if a patient has simultaneously thick secretions and respiratory dysfunction, so the combination may lead to increasing difficulties coughing up the secretions, which then might make them panic and then cause further respiratory distress. And it's not uncommon for patients to worry that they're going to die from choking as such. For the tenacious secretions, frozen dark grape juice to suck, normal saline nebulizers, and mucomist 3 to 4 mils 3 to 4 times a day by nebulizer. Some people think that pawpaw, pineapple juice, have got effect in breaking down mucus as well. For dry mouth, add water to meals. Check the medications. Sometimes what happens is we start medications because someone is drooling, and then we use too high a dose, and then you end up drying them out instead and giving the thick secretion, so we alter the dose accordingly. Avoid dairy products, because there is a school of thought that milky products can cause mucus and thick secretions. Artificial saliva, diluted lemon juice, pilocarpine mouthwash, and biotin mouth products. In terms of medications that we use, I tend to use the tricyclic antidepressants when the patient can still swallow, because as well as helping with the secretions, you might have the added effect of helping with things like depression and emotional lability. And when that doesn't work, I tend to go to glycopyrrolate over hyoscine or atropine, because glycopyrrolate doesn't cross the blood-brain barrier and may not cause the altered consciousness or sedation or delirium that you get in some other patients. The glycopyrrolate we give subcutaneously. You can either start a driver with low dose over 24 hours or 200 micrograms BD. Some people, there are case reports of glycopyrrolate being used through a nebulizer, but I think one patient developed a rash after this. But you have your options, and particularly in the community setting, or if you have a patient who's needle phobic. So you adjust, you choose. It's almost like it's customizing the treatments for the secretions. And then also clear secretions, chest physiotherapy, breathing techniques, nebulizers, cough assist device. The Botox injections are really just wonderful. I think that we tend to use this more commonly and earlier because they are relatively easy to do, have less side effects, and can be repeated in 3 months. And neurologists tend to inject near the parotid gland, and it blocks nerve transmission to the organ, so you don't have as much secretions. I put radiotherapy and surgery up here. Radiotherapy, the problem with this is that, sometimes you can go the other way when you use radiotherapy. It's also got its side effects in the skin, and sometimes you can dry the patients too much. But I guess if nothing else is working, it is an option. And surgery, in the literature, there are ways that are described the way you can use surgery, but I guess you are looking at a frail population who may not tolerate an anaesthetic, and I don't know that it's really all that effective. I've never actually sent someone for surgery for drilling or for secretions. And then you have your miscellaneous symptoms, reflux. I think with someone on a peg with a peg tube, dispersible omeprazole can be used, dependent edema, and urinary urgency, which you would treat accordingly. So, I just want to briefly say the issues with interventions, and by this I'm talking about the more aggressive ones like starting BiPAP or putting in a peg tube, is that, you know, when you start this, the indication shouldn't just be for survival, it should also be for quality of life. And it's important that these interventions don't reduce discussion of the future, because the disease will progress. And we have to be honest when we tell our patients about the effectiveness of interventions, and we should not let it hinder us from discussing dying and preparing the family and advanced care planning. So, emotional lability and dementia. Emotional lability, 20 to 50% of patients with ALS, probably more common in bulbar disease. It's not a mood disorder as such, and I've listed the treatments above. Frontotemporal dementia occurs in 5 to 10% of people who suffer from MND. And cognitive impairment in the literature has been reported to be as high as 60%. And this does interfere with planning and executive function and capacity to accept change. So moving on to psychosocial and spiritual issues. Depression, the prevalence is not really well defined. Clinical major depression we see in about 9 to 10% of patients. And this is not necessarily associated with the severity of the illness. And we treat this by being there, by supporting the patient, psychotherapy, spiritual and social support, and antidepressants. Now, I'm just going to go back to Tony Judd, and I just think he's such a brilliant writer, and we're just talking about what do patients worry about. I mean, forget depression. What you and I, just normal people, what are the normal concerns of the patient and the family? And he wrote about MND. Helplessness is humiliating, even in a passing crisis. But imagine the mind's response to the knowledge that the peculiarly humiliating helplessness of ALS is a life sentence. We speak blithely of death sentences in this connection, but actually the latter would be a relief. There is no saving grace in being confined to an iron suit, cold and unforgiving. The pleasures of mental agility are much overrated. Much can be said of well-meaning encouragements to find non-physical compensations for physical inadequacy. Loss is loss, and nothing is gained by calling it a nicer name. So this is what people worry about. How will I be cared for? Will I be dependent? Will I be a burden on my family? How will I actually die? Will I die at home? Can I stay at home until I die? Do I go to a hospital or a hospice? What does the family worry about? From time of diagnosis, well, how will I communicate with my loved one? Isolation, sexuality and intimacy, financial issues, and just all the other things that come along with death and dying. Spiritual aspects, which are not necessarily religious, the meaning of life, existential concerns, why me, fears of dying and fears of death. And in the motor neurone disease patient, particularly, people do worry about choking, they worry about pain, and they worry about dyspnea. So this is what they're worried about, and some studies have been done into what happens at the end of life, just a handful of studies in motor neurone disease patients, and this is what we can tell them. Most patients will die of respiratory failure. I've just put one of about a handful of studies up, but this is what we can say. Most patients will die peacefully. You're looking at figures like 90 to 98% of patients and their carers who reported a peaceful death. That home death is feasible in a significant proportion, that there are palliative measures, and that no one died choking. I think that's quite comforting. And so with end-of-life care, symptom control is important, as is anticipation, and communication is key with the patient and their family and carers. When do you plan for end-of-life care? As I said, at time of diagnosis, I think it's important to say, we can't cure you. There is no cure for this illness. And to take a palliative approach from diagnosis. Decision points, when it's time to put in a PEG tube, or when it's time to use BiPAP. Then you would have to look at where he or she is at that particular point of their trajectory and say, well, do you want this? What do you want? What are you hoping for? Crises, someone develops a chest infection, and obviously when someone is clearly terminal. And what must we discuss? Issues, difficult issues, resuscitation, sedation, hydration and feeding, talking about death. It's not uncommon that people will ask about euthanasia or want to talk about euthanasia, which in itself is another lecture. just to nip that one in the bud. So the terminal phase, what do we see? The deterioration is usually over a few days or hours. So you see someone not wanting to eat or drink, and I realise there is a spelling error there which is really bugging me. Not wanting to eat or drink, not wanting to engage. They're more sleepy, they're more weak. There's a reduction in chest expansion. They've got this irregular, rattly breathing and colour changes in the hands and feet, and their skin temperature becomes cold. And it's at this point in time very important to prepare the family just to explain what signs to expect and say that this is what is normal. We anticipate this, so please don't worry about it. We will make him or her comfortable. We tell the family who to contact for immediate advice, especially if they're in the home setting, how to involve others, additional comfort items, and managing the moments following death, funeral directors, that sort of thing. We share care plans. We make sure there's adequate nursing cover and comprehensive symptom control, and also good psychosocial support, and we enlist family and friends to support the primary carer. The end-of-life medications that we commonly use, morphine, midazolam and glycopyrrolate, and we tend to give drugs through the subcutaneous route. We don't like using cannulas that may fall out, and obviously patients, most of them will not be able to swallow at this point in time. And we withdraw equipment and unnecessary interventions, and so we've talked about weaning from ventilation, oxygen. It's also very important that, it's just such a dreadful disease, and it's such an intense time, not just for the families, but also for healthcare professionals. I think it's very important to recognise and acknowledge the impact on ourselves, on yourself, and to refer the family and the carer to the appropriate bereavement services. So I would like to conclude by saying that a palliative approach from time of diagnosis and multidisciplinary care is optimal, that complications need to be anticipated, discussed and planned for, that family and caregivers need to be included in all aspects of care, and that the patient's deterioration and death will be remembered forever by the family. And so be honest and sensitive and empathic and understandable and direct, but have a constant balance of hope with realism. And be aware of your own need for support and feelings to prevent compassion fatigue. And I think you're having a talk on that as well this afternoon.